Good afternoon, everyone, and thank you for joining us for today's webinar. This is yet another installment in the opioid webinar series that us at the Forensic Technology Center of Excellence here at RTI are putting on. The rates of opioid use and misuse have reached epidemic proportions and are impacting many aspects of both criminal justice and forensic science programs. Opioid addiction is the driving force behind this increase, in use with nearly 3 million Americans reporting a substance use disorder to prescription pain relievers or heroin in 2015, fueling a steady increase in fatalities to an estimated 91 U.S. deaths daily. These rates are not slowing, rather they are doubling, quadrupling, or undergoing even more alarming increases in some areas. Law enforcement, medical professionals, laboratories, and legal agencies are battling with unmanageable caseloads, economic shortfalls, and challenges for safety, analytical preparedness, and basic education and training. Reliable surveillance and intelligence are needed more than they have ever been, confronted with the fast-paced emerging drug life cycles. The legislative quagmire is just as burdensome, as policy change cannot happen without the data to support change. This webinar series will bring a multifaceted perspective to how diverse criminal justice disciplines are addressing these challenges, sharing their knowledge, and advancing science, technology, and law. Dealing with the impacts of the opioid crisis to the criminal justice system requires better reporting, surveillance, research, technology, and policy than are currently in use. The need to understand the epidemic and its effects goes beyond knowing your own profession. It takes a global perspective to fully act and make a difference. My name is Josh Vickers, and again, I am with the Forensic Technology Center of Excellence here at RTI. Today's webinar is being brought to you by two RTI personnel. The title of today's webinar is Making the Case for Prevention, Fighting the Opioid Epidemic. Our first presenter is Dr. Philip Graham. Dr. Philip Graham is a Senior Director of RTI International's Drugs, Violence, and Delinquency Program with the Center of Justice, Safety, and Resilience. He has over 20 years of experience conducting community-based research and evaluation. Since joining RTI, Dr. Graham has directed or collaborated on several projects focusing on the prevention of adolescent interpersonal violence and substance abuse. He currently directs several large-scale national cross-site evaluations of communities' efforts to build prevention infrastructure and leverage existing resources to reduce substance abuse and related problems using evidence-based strategies. Our second presenter today will be Dr. Elvira Ellick. Dr. Ellick is a public health analyst in the Drug Violence and Delinquency Prevention Research Group in the Center of Justice, Safety, and Resiliency. For more than 15 years, Dr. Ellick has worked as an analyst, project director, and co-investigator of multiple community-based evaluations and research studies related to substance use prevention interventions. The evaluation of the Keeping It Real culturally targeted and school-based substance use prevention intervention, a look at intervention adaptation to rural settings, a longitudinal examination of peer intervention in substance use, and contributions to the development of evaluation leadership of an alcohol prevention intervention based on media literacy and active planning of messages. Now, without further ado, we have a great presentation in line for you today. I would like to go ahead and switch everyone's layout to our presentation and hand things over to Dr. Graham and Dr. Ellick.
Good afternoon, and thanks, Josh. I want to thank my colleagues at RTI for providing us with an opportunity to talk about and think about the opioid epidemic from a slightly different perspective, and that is one of prevention, and hopefully we will make the case that it is a critical and important piece in this effort. As most of us know, it's almost impossible to turn on a television, read a newspaper or magazine, surf the web, or even access a social media platform and not consume multiple stories about the horrible impact of the opioid crisis on some individual family or community. And almost everyone knows someone directly or of someone who has been impacted by this crisis. And as we also know, we talk about universal threat to family stability, employment, economic development and growth, education, incarceration, health, and well-being. And that's the big challenge that we are faced with. However, we also know, and I speak from a position as a prevention scientist, that we cannot treat ourselves out of this problem. And so there are three things that we'd like to attempt to accomplish during today's presentation. One, make the case for prevention as it relates to the opioid crisis and really talk about the why we make that case. Then my colleague and co-director, Dr. Byra Ellick, is going to talk about what is SAMHSA's response, and particularly I'll talk about the Center for Substance Abuse Prevention's response in terms of the crisis, and then what has been RTI role as a national cross-site evaluator. And she'll actually show you some of the data that we've been using to look at this epidemic from a prevention perspective. And then I want to spend a little time at the end really talking about opportunities for both collaboration and partnerships and how you might be involved in this effort from a slightly different perspective. I show the following two maps, and I am sure most folks have seen them multiple times, but this is what drug overdose deaths looked like in 2002, red showing the areas in the country most elevated. And then looking at that same map in 2014, and visually it really points to the challenge that we have. We also know that the demographics of those deaths tend to be slightly older and among Caucasian males. But one of the things that we wanted to share and talk about is kind of where it's happening. As we also know in terms of where these deaths are occurring, first starting mostly with common prescribed opioids, but seeing that tapering off with an uptick in heroin and, more importantly, synthetic opioids. But here's where I'd like to stop and really begin to make the case that we hopefully will do today. So this really shows percentage of all admissions to substance abuse treatment centers that have either been attributed to the injection of any opioid by year and age. And while we tend to look at these older populations in terms of the epidemic, I want to focus here on this 18 to 29 and really talk about the importance of looking upstream instead of looking at the epidemic itself. So our challenges really from a prevention standpoint is what I often refer to as building a prevention plane as we fly it. As a prevention scientist, typically we want to build a strong body of evidence and then have individuals to start taking up those potential strategies. What we've had to do because of this epidemic is really focus on it in real time. But I want to make a distinction between preventing deaths and preventing overdose. And while that is where our attention needs to be paid in this moment, that in and of itself is not going to curb this growing epidemic. And so when we talk about prevention, we really are talking about looking upstream. So our challenge as prevention specialists are a couple things. One, why is prevention important? And I alluded to that. And what we really want to do is to prevent misuse and abuse before we ever have to tackle with issues of treatment, overdose deaths, and also morbidity and mortality attached to it. And so in doing that, we talk about looking upstream. And why is that important? As I've said, the conversation about opioid epidemic has rightfully focused on preventing overdoses and death, but these are the consequences associated with the epidemic and not the causes. Like any epidemic, its eradication rests on our ability to reduce the risk factors, and that in turn requires an understanding of root causes. So when we talk about looking upstream, we mean we must understand the causes of misuse and abuse. It also means understanding the difference between addiction that's associated with pain management versus misuse associated with social determinants of health. That's including poverty, unemployment, despair, and poor access to health care. And finally, it means understanding and addressing how these antecedents impact both supply and demand. So in doing that, we highly encourage that any effort must, one, be comprehensive and ecological in nature. And what that means is that we have to think about not only tackling from one perspective, but multiple perspectives, and then across the ecological spectrum. That means, what does it mean to intervene at an individual level? What does it mean to intervene at a family level? And what does it mean to intervene at a community level? So I want to transition to talk about what has been SAMHSA's role in this. And SAMHSA is the Substance Abuse Mental Health Services Administration, which is divided into three centers: the Center for Substance Abuse Treatment, the Center for Substance Abuse Prevention, and the Center for Mental Health Services. And our work primarily focuses on work conducted out of the Center for Substance Abuse Prevention. And so when we talk about SAMHSA's response today, it is primarily focused on that. Then after I've talked and given you an idea of some of those efforts, Elvira will come on and talk about what our role has been as an evaluator and really trying to understand what prevention strategies have the greatest opportunity to tackle this epidemic upstream. So what you see now are what we call SAMHSA's three-legged prevention stool. I'm going to talk about the first two because the third is a piece that really focuses on preventing overdose deaths. And what we want to talk about today is really those things that happen prior to that. So there are two major initiatives. One that's called the Strategic Prevention Framework, Prevention Partnerships for Success. And the second is called, which is a new initiative, Strategic Prevention Framework for Prescription Drugs. I will provide a description of each of those and what their intended objectives are, and then we'll begin to talk about some findings from the first of those two. So, Partnerships for Success. It has a couple priorities. One is to prevent and reduce the progression of substance use, prioritizing underage drinking among people age 25. The other part of the initiative is the piece that we'll talk about today, and its efforts to focus on prescription drug misuse and abuse among people aged 12 to 25. Again, not looking at the current population that's been most affected by the opioid epidemic, but moving upstream to a younger population and really understanding what are the risk factors that drive substance misuse and prescription drug misuse and abuse at that age. Because we believe if you can reduce those numbers significantly, you will impact the epidemic over time. In addition to these target areas, it is to reduce substance use-related problems associated with opioid use and prescription drugs, but also building and strengthening prevention capacity and infrastructure at both a state and community level. And finally, leveraging, redirecting, aligning state resources and funding streams and reach for prevention. We'll talk more about leveraging and redirecting and aligning when we talk about partnerships in the end. Right now, about 69 grantees, and that's a combination of states, tribes, and territories, have been funded and providing resources and strategies in about 652 communities across the U.S., which provides us a wonderful opportunity to look at population level changes in efforts to address this crisis. As you see in this map, it shows a distribution, and again, all 50 states except for Idaho are participating in this initiative, and within those states, there's a range of strategies from 3 to 4 to up to 40 types of different interventions being implemented in these various communities. As you'll see in this slide, grantees could again look at underage drinking. What we are talking about here is focusing specifically on those grantees who are looking at prescription drugs and opioids. And so there are about 44 grantees, and again, those grantees are comprised of states, tribes, and Pacific jurisdictions. There are 5 main questions that we're looking at. The first is, was the implementation of the Partnerships for Success programs associated reduction of prescription drug misuse? We also look at the variability in terms of how funding impacts those outcomes. We also, and one of the critical things we're interested in is what intervention type or combinations of interventions and dosages of those specific interventions were related to outcomes both at a grantee level and a community level. Similarly, we're looking at what types of combinations are most cost effective, an area of accountability, and really maximizing limited prevention resources. We've been tasked with trying to determine not only what's working, but what seems to be most cost effective. And then the last question is really looking at variability. So are outcomes attached to strategy types, how well they were implemented, geography or demography in terms of where interventions were implemented, and also barriers to implementation. The next program, which is a new program, is called the Strategic Prevention Framework for Prescription Drugs. So again, it's a smaller program in about 25 states and tribes, smaller dollar amounts, about up the range of, on average, about close to $400,000, and attempting to do a couple things. One, to implement statewide interventions and fund community efforts to implement local interventions. And by contrast, all of these interventions are at the community level, none at the individual level. And I mentioned earlier the importance of looking at strategies that look at individuals, families, and communities. So what is its intent? It first wants to raise awareness among youth and adults about the dangers of sharing and misusing prescription medications, also to promote collaboration between states, tribes, and pharmaceutical and medical communities to understand risk of overprescribing, also to implement prescription drug prevention activities and education, and then also to build a infrastructure and incorporate the use of prescription drug monitoring data and systems in terms of needs assessment and strategic planning. There are four main questions. The first is to really look at the impact of the implementation of this intervention to reduce prescription drug misuse and abuse. Also to understand how grantees use the prescription drug monitoring data to improve prescription drug outcomes. And also what barriers and facilitators affected implementation outcome and how the grantees address these barriers. And then the last question, I'm sorry, there were three questions. And so what I want to do now is to turn it over to Dr. Ellick, and what she's going to do is really talk about what those interventions look like for the first program I mentioned, which is called Partnerships for Success, and really talk about some of our early and preliminary findings. So with that, I'll turn it over to Dr. Ellick.
Thank you, Philip. And so a couple of things that I wanted to emphasize at the outset is that generally these Partnerships for Success grants from SAMHSA go to grantees, so they're state-level grantees, and in some cases tribal organizations or Pacific jurisdictions. Then those grantees, in most cases, provide most of their Partnerships for Success funding to communities throughout their geographic area. So they fund what we label as subrecipient communities or community subrecipients to actually implement interventions in various communities within their states. States end up doing this in very different ways. So, you know, some of the grantees end up providing smaller amounts of funding to a lot of different community subrecipients so that kind of the intervention is spread across the state, but maybe not as intensive in each geographic area. And in other cases, the grantees fund just a few communities within their state, usually the ones with the highest need for either underage drinking prevention or, as we're talking more about today, prescription drug misuse prevention. And those, you know, in that cases, those communities generally get a little bit more funding so that they could do things a little bit more intensively in that particular community. And what do Partnerships for Success communities do? A lot of different things. So these communities, and again, this varies from grantee to grantee. SAMHSA encourages the grantees to use evidence-based programs, policies, and practices. to do this kind of work. But in some cases, and especially with prescription drug misuse, there isn't as clear a link, especially when you talk about some of these prevention education programs and other things. They haven't shown as clear a link yet, or they haven't tested the link between these interventions and an actual impact on variables related to prescription drug misuse. In other cases, there's a lot of other interventions going on, like, say, physician education, prescription drug takebacks, other interventions along those lines that could be considered more environmental, impacting the environment of the individuals that may be thinking about misusing prescription drugs. And those types of interventions, oftentimes a lot of those have not been tested yet for effectiveness. So there are some of these challenges in the prescription drug area that for underage drinking, a lot of these interventions have been around for a lot longer, have been tested for a lot longer time. Okay, so some of the things we wanted to find out, and some of the things I'll be talking about next, is what exactly are these community subrecipients implementing when it comes to their interventions under Partnerships for Success. How many different types of interventions are they implementing? You know, what are the types of those interventions? What parts of that, Philip talked about that ecological level, so individual, family, peers, community, institutions. So what levels of that are they targeting most often? Are communities implementing what could be considered evidence-based strategies, and how do they know if these strategies are evidence-based or not? And are communities using this funding to implement new interventions in their communities, or are they using it to help fund some interventions that they may have used in the communities before? Okay, so what we found, and this is actually since the beginning of the Partnerships for Success grants, so in some cases for those PFS 2013 grantees that got funding in 2013, this has been maybe interventions that they've been implementing since 2014, 2015. So some of these things have now been in place for 3 years or so. Some of these interventions have only been in place for maybe the past 6 months. So there's a big range in how long these interventions have been implemented. So through fiscal year 2016, 339 subrecipient communities funded through the Partnerships for Success program implemented 1,197 interventions targeting prescription drug misuse. We've also looked at some data that shows that they've reached over 10 million individuals with these interventions. So the average number of prescription drug interventions implemented by any subrecipient community was 3.5. There was a large range from 1 intervention implemented in a community to 26. And again, as I described before, some of that had to do with higher amounts of funding in the ones that were implementing more interventions. A lot of it had to do with the types of interventions they were implementing. Some of the community subrecipients focus more on really informing people and those types of informational strategies, so informing people about the risks of, having prescription drugs in your home, for example, and, making sure that you're using safe disposal techniques. So some people focused on things like that, maybe did a lot of different sessions to get that information out. So that was more interventions. Some of them focus much more intensively on maybe a larger media campaign, or more on prevention, a more intensive prevention education thing, maybe something that they put in all of the schools in their communities. So it was really a range of things that were done. So some of the ways we've categorized these things to try to help us get a handle on what communities are actually doing to help prevent prescription drug misuse is we looked at what the Center for Substance Abuse Prevention in SAMHSA calls their strategy types. So these are different large categories of different kinds of strategies that they could be doing. And what we found is when we looked at that of all the interventions that were implemented for prescription drugs so far under Partnerships for Success, 21% of those are media campaigns. 22% of those are environmental strategies. So that would be this green block down at the bottom. And again, those environmental strategies can consist of a lot of different things. Oftentimes those, and I'll show you that in a slide in a second, were things such as prescription drug takebacks. 18% of the interventions were more information dissemination. So we've actually made this distinction between media campaigns and information dissemination ourselves. So the media campaigns were something that was more intensive, more different types of spots. Maybe they use TV, radio, and public presentations and a number of other things. Where information dissemination, those types of activities were more one-off types of activities, or maybe they just did a few things related to it. So there's a different level of intensity there. About 20%, and that's that orange slice of the pie, were prevention education activities. Those tended to be things that took place in schools, or maybe they might have been prevention education with parents. And a lot of these prevention education activities are some of those that are considered evidence-based for things like underage drinking, for example, and they've also applied them to prescription drug misuse. And then finally, we have 10% of the activities that were considered more community-based, 8% that were considered alternative activities. So those could be things like having a SAD club, Students Against Drunk Driving, but against prescription drugs, for example, or having a concert on campus or some kind of promotional event on campus that was an anti-drug thing. And then finally, what we're seeing, at least for the Partnership for Success grantees, that relatively fewer of them are using a problem identification and referral strategy for prescription drug misuse. So that would be something like if they visited their physician or they did an online thing to see if they might have an online quiz to see if they might have a problem with prescription drug misuse, and then they were referred to help from there. Okay, so I mentioned a little bit about the service types that were implemented most often for prescription drugs. So you can see that 15% of those were media campaigns, and 8% of those were either prescription drug drop boxes or take-back activities. 7% of those were speaking engagements or community presentations, so that would have been under that information dissemination category. Under education, we had 6% of the overall interventions were classroom educational services, but another 5% were other types of education. This is an important category, and we actually expect to see more of this training of educational environmental influencers in the prescription, the partnerships for the Strategic Prevention Framework Prescription Drugs grants. We expect to see them doing a bit more of this training of educational or environmental influencers. So these could be things like having trainings for healthcare personnel on prescribing drugs, or on law enforcement for what to look for in terms of in relation to prescription drugs. Okay, so again, back to this ecological model, and we found that 52% of these interventions are actually addressing whole communities. where 20% are focused more on individual young people, 10% on families, and 11% on institutions or organizations that could influence young people. And again, this 52% for whole communities, a lot of that is the media campaigns and the environmental strategies, the take-back days, that kind of thing, are really focused more on the whole community. Okay, so in terms of whether or not these interventions were evidence-based, we found that yes, 43% of them were considered to be evidence-based, and this is as reported by these community subrecipients on the surveys that they have to complete. For 50% of them, 57% of them, they either said no or that they didn't know if they were evidence-based strategies or not. Of these evidence-based strategies, 51% of the community subrecipients indicated that they know that they're evidence-based because their grantee provided them a list of strategies that the grantee said was evidence-based. Another 40% said that they actually found them on some kind of federal registry of evidence-based programs, policies, or practices. So this is something that I know SAMHSA and ourselves are working on more, both to figure out how to make sure we get more of these prevention interventions defined as evidence-based, or find out if these things are actually effective so that we could show that they are evidence-based interventions. So that's definitely an area that folks need to work on more for prevention of prescription drug misuse. Finally, I wanted to point out that as opposed to the 43% of strategies that were considered evidence-based for prescription drugs, overall, when we look at all the interventions implemented for Partnerships for Success, 51% are considered evidence-based. So again, this is an area that for prescription drug misuse, we really have to think about that gap and really work on building an evidence base for these prescription drug misuse prevention activities. Okay, and the final couple of things to talk about is a lot of these interventions, over half of them, are considered universal indirect approaches. So again, these are things like media campaigns, drug take-back days, while 35% were considered direct approaches. And a lot of that is like having information sessions, with individual community members or doing a prevention education type program. Another important thing is that 62% of all these interventions had not been implemented in these communities prior to Partnerships for Success. So again, this is a good way to show that a lot of what SAMHSA is supporting here is new activities, new prevention activities that would not have been in these communities without SAMHSA's help. Okay, so there are a couple of other things I wanted to talk about. So one of the important things with these, I talked about the gap in the evidence base. So one of the things that we want to know as prevention researchers is which of these interventions are actually more effective. As I indicated before, this is a little bit challenging, with this type of cross-site national evaluation. Folks are implementing a lot of different things. And it varies from state to state. There are a lot of other factors in there. But there are a couple of ways that we're starting to look at this. And we're still relatively early on the outcome side of things. So these findings are going to be relatively preliminary, but we're hoping to build more of this evidence base over the next few years. And one of the ways we're doing that, to understand what combinations of interventions are implemented by Partnerships for Success communities and see which ones are more effective so that we could help providers make more informed selections in terms of their interventions. We use this, so I'm going to talk about this technique called qualitative comparative analysis that we're using. Again, this was focused on the PFS 2013 cohort. So these were those grantees that were funded in 2013 to do these interventions. And that was 16 grantees that have about 225 funded community subrecipients. Not all of them had begun implementing interventions through FY 2016, what this outcomes data is for. And not all of them have provided enough follow-up outcomes data to really look and see if there were follow-up outcomes for what they've been doing so far. So again, this is a relatively preliminary analysis, but it's giving us some ideas of what at least is going on with the combinations of interventions that grantees are implementing. So again, as Philip pointed out, 12 of the 16 grantees are specifically targeting prescription drugs. And of the community subrecipients that are implementing interventions so far, 136 of those specifically said that they were targeting particular interventions at prescription drugs. 80 said that they were targeting them at things like prescription drug-related illnesses and deaths. 58 said that they were targeting specifically overdose for prescription drugs, and 61 said that they were specifically targeting emergency room-related visits related to prescription drugs and other substance use. Okay, so I already talked about qualitative comparative analysis and how we were using that. I'm not going to go into too much detail here. If folks want to follow up with us after this presentation, I'd be happy to talk a little bit more about it and definitely connect you with our analysts that did a lot of this work. But basically, it's a more qualitative approach. It uses things like truth tables that look at whether or not interventions were implemented, whether or not there were good outcomes for different patterns of interventions, and I'll show that in a minute. And it's really looking at pathways. You know, what combinations of interventions help to regularly produce positive outcomes, and how consistently they produce those outcomes, and if we could use a combination of different intervention combinations to show most of the positive outcomes, to cover most of those positive outcomes, so we could recommend these as the things that most often lead to positive outcomes of prevention activities for prescription drug misuse. Okay, we got the outcomes data from existing archival and survey data sources. Grantees are the ones that actually submit the data to us. We focused on past 30-day prescription drug misuse outcomes, and basically we labeled the outcome as positive if there was any decrease in prescription drug misuse reported over time from one year to the next, and 0 if there was no change or if there was an increase in that. So we have very simple coding for the outcomes for this. So this is the truth table I was talking about for prescription drug misuse. And as you can see, so this provides combinations of the different CSAP strategy types that I talked about. In this particular case, all those media campaign activities are listed under this information dissemination column. And you'll see that, so this column shows you the number of subrecipients that have the particular combination of interventions. So if you're looking at the first row, in that particular case, it's subrecipient communities that implemented both prevention education and information dissemination. So there were 17 communities included that did that. The second row, it's environmental strategies and information dissemination is what they implemented. And there were 11 communities that did that. The other thing to look at in this kind of truth table is how many actually had successful outcomes. So how many out of those interventions, what percentage out of those interventions actually reduced prescription drug misuse? So on here you can see that the most successful ones from this particular table, and again, this is really still relatively preliminary analyses, is that about 70% of the community subrecipients that implemented information dissemination actually showed a reduction in past 30-day prescription drug misuse. But a lot of these most common intervention combinations, so whether it was the prevention, education, and information dissemination in the first one, only 41% of those communities showed a reduction in past 30-day prescription drug misuse. Again, relatively early in their implementation of these interventions. Okay, this is a similar truth table, but with those ecological targets. So we have individual young people, family, friends or peers, institutions and organizations, whole communities, and then public law or policy. These are the most commonly implemented combinations. And again, as we said, it's like over 50% of the interventions targeted whole communities. And what we found is that was the most common combination, was just that, just targeting the whole community. So they may have implemented 2 or 3 interventions, but each one of them just targeted the whole community. Again, what you'll see here is we don't have a lot of consistency in the outcomes. So anywhere from 20% that targeted whole communities and friends, we got 20% reduced prescription drug misuse, up to 62% for those that targeted family and whole communities. So the main takeaway of this now, and why I keep emphasizing the fact that this is still preliminary data, is we're looking for additional outcomes, is that lack of consistency so far. But again, they haven't had that much time to demonstrate those reductions in prescription drug misuse. So there were some pathways that did show that they seem to be successfully producing positive outcomes. They weren't necessarily consistent, and they accounted for relatively few cases, but we expect that to change over time. So we really need to assess the timing of the full implementations of the interventions. We need to make sure that we're including some of these later cohorts that were funded after PFS 2013, so we cover a lot more communities, really look at some of these longer-term outcomes, explore additional factors that may account for successful cases. Like one of the things we're looking at is the capacity of these communities to actually implement these prevention interventions. And we really need to take, in these analyses, better account for the substances that were actually targeted by the subrecipients. Okay, the one other type of outcomes findings we looked at is poisoning call center data. And for this, the NPDS data set that we used has 60 million poisoning call cases dating back to 1983. We looked at the most recent data, so that covered the Partnerships for Success period. So that was from fiscal year 2012 through fiscal year 2016. We only looked at cases that included individuals that were ages 12 to 25 for our prescription drug domains, and 12 to 20 for ethanol or alcohol. The prescription drug categories that we included in our data sets were antidepressants, sedatives, stimulants, and opioids. Okay, these are individual cases. For our analyses, we aggregated them up to the community level because, again, that's where most of these interventions occur. And then we converted the numbers, the raw numbers we got, into poisoning rates. And what we really wanted to do is compare communities where Partnerships for Success was implemented to communities where it was not. So again, I'm going through these slides a little quickly in the interest of time. But this shows you the main outcome that we found so far, is that we did see an effect on the overall poisoning calls, and this is across those category types, so prescription drugs and alcohol. And I can tell you this was mainly driven by prescription drugs because the number of ethanol or alcohol calls are relatively low. Okay, so what we found is reductions in risk over time for poisonings at the community level, for partnerships for success communities as compared to non-partnerships for success communities. And again, calls went up, as could be expected with a lot of the other data we've seen with the increase in issues with prescription drug overdoses. But in partnerships for success communities, those calls, and this is that bottom orange line that you see, those calls actually stay pretty stable over the course of time that we're looking at so far for partnerships for success. Okay, so that gives you just a little bit of an idea of some of the interventions, prevention interventions that are being implemented for prescription drug misuse, and some of these preliminary outcomes that we're starting to see to show whether or not these interventions are effective. And with that, I am going to pass it back off to Philip so that he could talk about collaborations and partnerships.
I will go through the collaborations piece pretty quickly because we did want to make sure we left as much time as possible to hear from you. Just quickly, our work to date tells us that if we are to win this public health challenge, primary and universal prevention efforts must occur through collaborations at multiple levels. What I want to briefly talk about and also give credit to is kind of opportunities for collaboration. The list of that you see here is not mine. I read a wonderful article about work going across the country, and so I kind of taken from that to frame. Here are potential collaborators that we can think about, and so I'll highlight a few in an effort again to open it up for questions. But as we think about being both primary prevention as a focus and a universal application, again happening at multiple levels. So if we're talking about scientists and really looking at how we develop different drugs that are less addictive and or better ways in which to manage pain, and figuring out how we collaborate to make that point is an opportunity for collaboration. We can also talk of working with commissioners, health department commissioners, and really focusing on launching what we call public health campaigns, and really as a way to educate the population. Others are in terms of working with prosecutors around diversion of those who are showing issues around substance abuse dependency, and really understanding the importance of getting folks into proper treatment, but working with prosecutors about how that looks and how that works in communities. Education is a key piece, and really focusing emphasis on how can we work with medical and nursing schools and incorporate in their training, understanding how to understand issues associated with opioids and its use, particularly with a primary focus on reducing overprescribing. If we think about drug designers, the challenge is how do we change the physical properties of prescription drugs so that they are much more difficult in terms of breaking down to be used for things other than pain management, and which we were also seeing in many communities. Another is in terms of working with the police department, first responders, and helping them understand how to use naloxone. And while I talk more about primary prevention as an example where we could talk about having naloxone boxes in places just like you have defibrillators. Another opportunity for collaboration. Working with activists and really around how do we change local policies in terms of how prescription drugs particularly are being distributed. And then the last one is quickly in terms of administrators. How can we work with state and county and commissioners who make policy and funding around these efforts? Very few states to date use local funding to address issues of substance use. Most of that funding comes through block grants. And so as we think about how resources are used, how can we convince and work with state legislators to assign local dollars locally to address those issues. So these are potential collaborators and partnerships that we all can figure out where we might have an opportunity to partner to, again, address this epidemic. As I said, I was going to go through this quickly. So in closing, our prevention challenges is following. We still are trying to best understand what are the most effective universal strategies to use with limited resources. More importantly, very few places implement a single strategy. So the other thing is, what are the most effective combinations of prevention strategies? And going back, as the virus said, across the ecological spectrum. And then really, how do we truly prevent opioid misuse and abuse prior to overdose and prior to death? So with that said, we want to thank you and leave you with this quote: success is not final, failure is not fatal, it is the courage to continue that counts. Again, on behalf of my team here at RTI, I want to thank you for, giving us the opportunity. With that said, Josh, we'll open it up for questions. And again, thanks to all for listening to us today.
All right, thank you very much, Dr. Graham and Dr. Ellick. We did have quite a few questions that came in. Before we get to that, I just wanted to make mention there in the bottom of your screen, you will find both of our presenters' contact emails. So before you leave, make sure to write those down just in case you have any follow-up questions. So we'll just jump right into the Q&A. The first question that came in asked, what is the estimated cost range of the intervention strategies, i.e. which strategy have the greatest labor and resource commitment, and what are the timelines for implementation of these strategies on average?
So I can answer that a little bit. So we recently submitted a report to SAMHSA where we first started looking at some of the cost of the intervention data. So far, again, this doesn't cover all the interventions or all of the grantees and their subrecipients yet. Generally, community subrecipients spend about $7,200 on any one prevention intervention, but it really varies by service type, and that's where we've looked at it so far, from about $1,700 for some of those information dissemination things like attending a health fair and handing out brochures, to over $12,000 for some of these other enforcement activities like the enforcement of local ordinances. Personnel account for 67% of the total expenditures, and this ranges from 50%, it accounts for 50% of some of the educational services, to over 95% for some of those things that focus more on changing local codes and ordinances and things along those lines. But we expect to have a lot more data about that out and available for folks in about a year.
All right. Next question we have came from Jane. She was asking, what was the main target audience for the media campaigns?
And so it's a combination. So again, there are some that are targeting that specific age demographic 12 to 25, and depending on whether it's done, for example, on the college campus, really focused on college age going, or a large majority really focused on communities. And so there it is at a community level, meaning it's intended to create awareness for youth and adults around particular issues around access, disposal, and the like, but it's pretty comprehensive and tries to, for the most part, encompass the entire community. Brian, I don't know if you want to add to that. Either you're on mute or you meant no.
I was just saying it does vary from community to community, but you know, so sometimes they might be addressing parents, sometimes youth, sometimes it you know, might be just to make sure people are aware of what things are out there, but generally it does address the entire community.
All right. Next question we have comes from Deborah Merritt. She's asking, do any of these outreach programs address the fake oxy and fentanyl tablets that are out there in the community?
Not that we know of specifically. I suspect that that's going to come up a lot more again under the Strategic Prevention Framework Prescription Drug Program than under Partnerships for Success, only because that SPIF-RX program is targeting it more specifically.
You know, this becomes, when you talk about partnerships working with DAA and other folks, as you may know, a lot, the fake oxy and fentanyl, the primary source is China, and so there is a big push on the supply side and law enforcement interdiction to curb that. It has been an ongoing problem because a lot of that is like sent through the mail, and keeping up with that has been a challenge. So again, education programs will focus on that, and we know that's one of the major new causes, and the current programs haven't focused on it specifically. It's been more of a law enforcement attempt, but something that clearly needs to have increased focus. Going to move to the next question, Josh.
Yeah, I apologize. I was still on mute. Next question is, are there any noticeable trends for results in rural versus suburban areas for PFS as far as the chosen strategies?
Anecdotally, I think there are. We have not analyzed the data in that way yet, but we do have some variables included in our data collection where we will be able to look at that.
All right, great. Next question is kind of a three-parter, so I can ask all three and then we can go one at a time, or we can revisit some of them. What are examples of the specific activities being done related to prescription drugs? And have any of these activities worked with community pharmacists? And what measures are there for evaluation?
So I think I mentioned some of the specific activities with prescription drugs. And again, this is more of a cross-site national evaluation. So it's hard for us to get at any individual intervention or any one of those individual things that the now over 500 communities are doing. But it could be anything from enforcement. It could be using one of those prevention education programs. There really is a lot of different stuff that's going on. See, the second part of the question was, like, Josh, can you help me out on that one?
Yeah, second part was, have any activities worked with community pharmacists?
And I can add, so the second program that we described, I think this is from Laura, was the Strategic Prevention Framework RX project. That's a new one. It specifically will focus on pharmacies and the pharmaceutical industry. So we can't answer the question today, but that's a new study that's starting that is specifically designed to work with pharmacists, which would include community pharmacists. And so each grant, there's 25 grantees, will on average select at least up to 3 to 5 communities to work with, and that will be a primary focus. And so we can't answer today, but hopefully within a year we'll begin to have more information, because that was added. Our first efforts were really looking at community efforts. The second efforts is really looking at doctors and prescribing practices, and then the other was naloxone distribution. So that second leg has just really been put in place in an attempt to be comprehensive. So check back with us in a year and we'll have more to say about that.
All right, and then the last part of the question were, what measures are there for evaluation?
Yeah, and I think this also answers a couple of questions down about some of the measures for prescription drug misuse. So on the outcome side, again, it's like the community level measures are really dependent on what the grantees provide us and what they have already existing in their states, tribes, and jurisdictions. Oftentimes to measure something like past 30-day prescription drug misuse, that data comes from existing surveys that are already in those states, tribes, or jurisdictions. So whether they're implementing the youth risk behavior survey from CDC, sometimes they'll use that. They'll have another school-based survey or something along those lines. Then for the process side of it, so the interventions and things like that, the communities actually fill out this instrument. It will be on an annual basis. We've been having them do it twice a year, where they provide us detail about what they're implementing, who they're implementing it with, what exactly they're doing. So we have a lot of rich, detailed information on that. So as we really dig into this data, we'll be able to get into more of what they're doing on the implementation side.
All right. Next question we have comes from Robert Bianchi. He's asking if you know what other agencies are doing to prevent prescription drug abuse and misuse.
Other agencies. So at the federal level, SAMHSA is really focused on communities, but in terms of opioids specifically, CDC has launched several initiatives focusing on naloxone distribution and guidelines to doctors around prescribing. So right now we know those are two large efforts. We also know, like, the National Institutes of Justice has begun also to look at funding efforts that really focus on law enforcement involvement. So I would say that for the most part, almost every federal agency now has been looking at some aspect of the opioid epidemic. I'm switching over from headphones, so hopefully that is better. Another example is the FDA is doing work around messaging and labeling as it relates to opioids. So almost the largest federal agencies now all have added components that has actually increased strategies to address particularly opioids and overdoses from multiple perspectives. So those are three different examples of federal agencies who are providing resources from slightly different perspectives to address the epidemic.
All right, great. Next question, it looks like we have two questions left. What power of sample size are you anticipating will give you the most statistically relevant information?
And I don't have the sample size power figures right at my fingertips, but I can tell you that, like the poisoning call data slide that I showed, that was, we are getting good effect sizes on some of this data, so we are already seeing that, and we are seeing significant effects at the community level. At the grantee level, it's a little bit more challenging because we only have a max of those 70 grantees. But most of these things that we talked about today are really more focused on that community level, and it is looking like we already have sufficient power there. What we need is a little bit more time. Time for folks to have all been implementing, and time for folks to have actually been able to provide us with follow-up outcomes data. Sometimes there's lags in that, so that's what's limiting our ability to look at outcomes more than anything else.
All right. Before we move on to our last question, Mary Hall was asking about the slide. For those of you that have stuck around with us after this question, when we move to our closing, we do have the ability for you to download a PDF version of today's slide deck directly from the room. So we'll go ahead and ask this question, then we'll move on to our closing. So Rebecca Perry stated, Philip and Elvira, thank you so much for the insightful presentation. She particularly appreciated the plane graphic. She was asking if any of these data or reports are available online, And if so, where can they find these reports?
Last year's report for Partnerships for Success, our evaluation report to SAMHSA, is online and available at SAMHSA's website. And I don't remember exactly what that link is yet, but you should be able to find it. And the next report that's going to be online will be our report for this upcoming year. So that should be available maybe 15 months from now. We have also done presentations in a number of conferences and stuff like that. So we also have those presentations that are available online in some cases. So if folks want to follow up with us about any of that stuff, we could send you some of those links.
All right, fantastic. Thank you so much. We are going to go ahead and move on to our closing. Before we close everything out, Dr. Graham and Dr. Ellick, do you have any closing remarks or closing words that you'd like to give our audience, where your research is going next?
I would, again, like to say thank you for folks. I was quite impressed by just the number of individuals on today's webinar and interested. We are looking forward to, one, gathering more data and continuing to make the case for prevention, which is not as straightforward in terms of looking at treatment outcomes. I am confident that we have a team capable of doing that and really talking about what's working well. So we are looking forward to this last year of the contract and maximizing our available data to really continue to examine where we're having the most effective outcomes related to community efforts to reduce prescription drug misuse and abuse.
All right. Thank you so much, Dr. Graham and Dr. Ellick, for taking time out of your day to deliver your presentation to our audience today. We definitely appreciate that. We would also like to thank our audience members for attending today. Without your attendance and support, these webinars just would not be possible. So definitely thank you for joining us. As I made mention, in the bottom left-hand corner of your screen, you will find a PDF version of today's slide deck. Simply click on the title of the PDF file, and then at the bottom, you can click the Download the Files button. That will allow you to download today's slide deck directly from the room. So make sure you get that before you leave. Also, before you leave, if you could please take our brief customer satisfaction survey. Your feedback about our webinars is vital information that we use to provide you with the best webinar experience, and also to adjust the content and also the way we disseminate it to you, our audience. So you can simply click the word "Here" there in the middle of your screen. It will bring up a new window for you that you can take our satisfaction survey. I have also opened up a new window for everyone that is still in the room. This will take you directly to our website, www.forensiccoe.org. Make sure to go check us out there and find out all of the no-cost webinars, reports, and information that we are putting out to the forensic community. Also, make sure to check us out on Twitter and Facebook and LinkedIn to stay up to date on all of our future offerings. We will have more opioid webinars coming to you very soon, so make sure to stay tuned for that. And again, thank you, Dr. Graham and Dr. Ellick, for joining us today, and thank you all of our participants. We hope everyone has a great afternoon.